Hi everyone, welcome to my webinar. My name is Lisa. Today's webinar is Psychiatry and Access Diagnosis Explained. What is an access diagnosis? The standardized diagnosis that is made according to the Diagnostic and Statistical Manual of Mental Disorders, 4th edition, and also known as DSM, Roman numerals 4. With this manual, there is 5 access systems of diagnosis that is used. The A in access is capitalized. So remember that, everyone. Always capitalize the A. And access numbers are transcribed using Roman numerals. So always use Roman numerals for access. Access 1. Clinical disorders. Disorders usually diagnosed in infancy, childhood, or adolescence. Mood disorders, psychotic disorders, cognitive disorders, substance-related disorders, sexual and gender identity disorders, adjustment disorders, eating disorders, sleep disorders, impulse control disorders, and factitious disorders. So as you can see, there's a lot of disorders. Type of mood disorders are, if you have a mood disorder, your general emotional state or mood is distorted or inconsistent with your circumstances. Some examples of mood disorders include major depressive disorder, that's prolonged and persistent periods of extreme sadness. Bipolar disorder, also called manic depression or bipolar affective disorder. Depression that includes alternating times of extreme sadness, which is depression, and extreme happiness, which is mania. Seasonal affective disorder, also known as SAD, a form of depression most often associated with few hours of daylight in the far northern and southern latitudes, from late fall to early spring. And yes, some of these areas, they only get like 4 or 5 hours of daylight. Can you imagine? That would be depressing, and that go on for weeks on end. And then there's cyclothymic disorder, and that's a disorder that causes emotional ups and downs that are less extreme than bipolar disorder. Premenstrual dysphoric disorder, mood changes and irritability that occur during the premenstrual phase of a woman's cycle and go away with the onset of menses. And there's persistent depressive disorder, which is dyspnea, a long-term chronic form of depression. And then there's disruptive mood dysregulation disorder. That's a disorder of chronic, severe, and persistent irritability in children that often includes frequent temper outbursts that are inconsistent with the child's developmental age. Depression related to medical illness. A persistent depressed mood and a significant loss of pleasure in most of all activities that's directly related to the physical effects of another medical condition. For most people, mood disorders can be successfully treated with medication and talk therapy. So in other words, psychotherapy. What is a oh my, I can't talk today, folks, sorry. What is a psychotic disorder? Psychotic disorders are a group of serious illnesses that affect the mind. They make it hard for someone to think clearly, make good judgments, respond emotionally, communicate effectively, understand reality, and behave appropriately. When symptoms are severe, people with psychotic disorders have trouble staying in touch with reality and often are unable to handle daily life. But even severe psychotic disorders usually can be treated. In types, there are different types of psychotic disorders, including schizophrenia. People with this illness have changes in behavior and other symptoms, such as delusions and hallucinations, that last longer than 6 months. It usually affects them at work or school, as well as their relationships. Schizoaffective disorder. People have symptoms of both schizophrenia and the mood disorder, such as depression or bipolar disorder. Schizophreniform disorder. This includes symptoms of schizophrenia, but the symptoms last for a shorter time, usually between 1 and 6 months. Brief psychotic disorder. That's what people with this illness have a sudden short period of psychotic behavior, often in response to a very stressful event, such as a death in the family. Recovery is often quick, usually less than a month. Delusional disorder. The key symptom is having a delusion, a false fixed belief involving real-life situations that could be true but aren't, such as being followed, being plotted against, or having a disease. These delusions last for at least 1 month. Shared psychotic disorder, also called folie à deux. This illness happens when one person in a relationship has a delusion and the other person in the relationship adopts it too. Substance-induced psychotic disorder. This condition is caused by the use of or withdrawal from drugs, such as hallucinogens and crack cocaine, that cause hallucinations, delusions, or confused speech. Psychotic disorder due to another medical condition. Hallucinations, delusions, or other symptoms may happen because of another illness that affects brain function, such as a head injury or brain tumor. Paraphrenia. This condition has symptoms similar to schizophrenia. It starts late in life when people are elderly. And the symptoms, the main ones are hallucinations, delusions, and disordered forms of thinking. Cognitive disorder. Mild cognitive impairment, which is also known as MCI, is an intermediate stage between the expected cognitive decline of normal aging and the more serious decline of dementia. It can involve problems with memory, language, thinking, and judgment that are greater than normal age-related changes. If you have mild cognitive impairment, you may be aware that your memory or mental function has slipped. Your family and close friends also may notice a change, but generally these changes aren't severe enough to significantly interfere with your day-to-day life and usual activities. Mild cognitive impairment may increase your risk of later progressing to dementia, caused by Alzheimer's disease or other neurological conditions. But some people with mild cognitive impairment never get worse, and a few eventually get better. Symptoms. Your brain, like the rest of your body, changes as you grow older. Many people notice gradually increasing forgetfulness as they age. It may take longer to think of a word or to recall a person's name, but consistent or increasing concern about your mental performance may suggest mild cognitive impairment. Cognitive issues may go beyond what's expected and indicate possible MCI if you experience any or all of the following. You forget things more often. You forget important events such as appointments or social engagements. You lose your train of thought or the thread of conversation, books, or movies. You feel increasingly overwhelmed by making decisions, planning steps to accomplish a task, or interpreting instructions. You start to have trouble finding your way around familiar environments. You become more impulsive or show increasingly poor judgment. Your family and friends notice any of these changes. If you have MCI, you may also experience depression, irritability and aggression, anxiety, and apathy. Brain shrinkage. There's no single cause of brain shrinkage. There's no single cause of mild cognitive impairment, just as there's no single outcome for the disorder. Symptoms of MCI may remain stable for years, progress to Alzheimer's disease or another type of dementia, or improve over time. Current evidence indicates that MCI often, but not always, arises from a lesser degree of the same types of brain changes seen in Alzheimer's disease or other forms of dementia. Some of these changes have been identified in autopsy studies of people with MCI. These changes include abnormal clumps of beta amyloid protein, plaques in other words, and microscopic protein clumps of pi, characteristic of Alzheimer's disease, and they're like tangles. Lewy bodies, which are microscopic clumps of another protein associated with Parkinson's disease, dementia with Lewy bodies, in some cases of Alzheimer's disease. Small strokes or reduced blood flow through brain blood veins or vessels. Brain imaging studies show that the following changes may be associated with MCI. Shrinkage of the hippocampus, a brain region important for memory. Enlargement of the brain's fluid-filled spaces, which is ventricles. Reduced use of glucose, the sugar that's the primary source of energy for cells in key brain regions. Risk factors. The strongest risk factors for MCI are increasing age, having a specific form of a gene known as capital APOE-e4, also linked to Alzheimer's disease. Though having the gene doesn't guarantee that you'll experience cognitive decline, other medical conditions and lifestyle factors have been linked to an increased risk of cognitive change, including diabetes, smoking, high blood pressure, elevated cholesterol, depression, lack of physical exercise, infrequent participation in mentally or socially stimulating activities. Complications. People with MCI have a significantly increased risk, but not a certainty, of developing dementia. Overall, about 1 to 2% of older adults develop dementia every year. Among older adults with MCI, studies suggest that around 10 to 15% develop dementia every year. Axis 2. It's all about personality disorders and mental retardation. So there's paranoid personality disorder, borderline personality disorder, antisocial personality disorder, dependent personality disorder, and mental retardation. Paranoid personality disorder, since childhood or adolescence, was socially withdrawn because of being suspicious, feeling victimized, and bearing grudges, not due to a medical or substance use disorder. Prediction lasts for years or a lifetime. Occupational economic problems can causes significant impairment in academic, occupational, and or social functioning. Works poorly with others, highly critical of others, yet hypersensitive to criticism of self. So it's one of those dish it out but can't take it kind of deals. Critical, quarrelsome, low agreeableness, suspiciousness. Suspects, without sufficient basis, that others are exploiting, harming, or deceiving him or her. Is preoccupied with unjustified doubts about the loyalty or trustworthiness of his or her friends or associates. Is reluctant to confide in others because of his or her unwarranted fear that the information will be used maliciously against him or her. Reads hidden, demeaning, or threatening meanings into benign remarks or events. Perceives attacks on him or her character or reputation that are not apparent to others and is quick to react angrily or to counterattack. Has recurrent suspicions without justification regarding fidelity of his or her spouse or sexual partner. Lack of forgiveness. Persistently bears grudges. Example, is unforgiving of insults, injuries, or slights. Borderline personality disorder, otherwise known to as BPD, is a serious mental disorder marked by a pattern of ongoing instability in moods, behavior, self-image, and functioning. These experiences often result in impulsive actions and unstable relationships. A person with BPD may experience intense episodes of anger, depression, and anxiety that may last from only a few hours to days. Some people with BPD also have high rates of co-occurring mental disorders, such as mood disorders, anxiety disorders, and eating disorders, along with substance abuse, self-harm, suicidal thinking and behaviors, and suicide. While mental health experts now generally agree that the label borderline personality disorder is very misleading, a more accurate term does not exist yet. Signs and symptoms. People with BPD may experience extreme mood swings and can display uncertainty about who they are. As a result, their interests and values can change rapidly. Other symptoms include frantic efforts to avoid real or imagined abandonment, a pattern of intense and unstable relationships with family, friends, and loved ones, often swinging from extreme closeness and love as an idealization to extreme dislike or anger, devaluation, distorted and unstable self-image or sense of self, impulsive and often dangerous behaviors such as spending sprees, unsafe sex, substance abuse, reckless driving, and binge eating. There's also recurring suicidal behaviors or threats, or self-harming behaviors such as cutting. Intense and highly changeable moods, with each episode lasting from a few hours to a few days. Chronic feelings of emptiness, inappropriate, intense anger or problems controlling anger, having stress-related paranoid thoughts, having severe dissociative symptoms such as feeling cut off from oneself, observing oneself from outside the body, or losing touch with reality. Seemingly ordinary events may trigger symptoms. For example, people with BPD may feel angry and distressed over minor separations, such as vacations, business trips, or sudden changes of plans, from people to whom they feel close. Studies show that people with this disorder may see anger in an emotionally neutral face and have a stronger reaction to words with negative meanings than people who do not have the disorder. Some of these signs and symptoms may be experienced by people with other mental health problems, and even by people without mental illness, and do not necessarily mean that they have BPD. It is important that a qualified and licensed mental health professional conduct a thorough assessment to determine whether or not a diagnosis of BPD or other mental disorder is warranted, and to help guide treatment options when appropriate. Tests and diagnosis. Unfortunately, BPD is often underdiagnosed or misdiagnosed. A licensed medical or mental health professional experienced in diagnosing and treating mental disorders, such as a psychiatrist, psychologist, or clinical social worker, can diagnose BPD based on a thorough interview and a comprehensive medical exam, which can help rule out other possible causes of symptoms. The risk factors. The causes of BPD are not yet clear, but research suggests that genetics, brain, environmental, and social factors are likely to be involved. Genetics. BPD is about 5 times more likely to occur if a person has a close family member, which would be first-degree biological relatives, with the disorder. Environmental and social factors. Many people with BPD report experiencing traumatic life events such as abuse or abandonment during childhood. Others may have been exposed to unstable relationships and hostile conflicts. However, some people with BPD do not have a history of trauma, and many people with a history of traumatic life events do not have BPD. Brain factors. Studies show that people with BPD have structural and functional changes in the brain, especially in the areas that control impulses and emotional regulation. However, some people with similar changes in the brain do not have BPD. More research is needed to understand the relationship between brain structure and function and BPD. Antisocial personality disorder. An adults-only diagnosis. Antisocial personality disorder describes individuals who tend to disregard and violate the rights of others around them. Antisocial personality disorder is best understood within the context of the broader category of personality disorders. A personality disorder is an enduring pattern of personal experience and behavior that deviates noticeably from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, is stable over time, and leads to personal distress or impairment. Symptoms: disregard for society's laws, violation of the physical or emotional rights of others, lack of stability in job and home life, lack of remorse, superficial wit and charm, recklessness, impulsivity, a childhood diagnosis or symptoms consistent with conduct disorder. Antisocial personality disorder is characterized by a pattern of disregard for and violation of the rights of others. The diagnosis of antisocial personality disorder is not given to individuals under the age of 18 and is only given if there is a history of some symptoms of conduct disorder before age 15. The severity of symptoms of antisocial personality disorder can vary in severity. The more egregious, that's a tongue twister, egregious, harmful or dangerous behavior patterns are referred to as sociopathic or psychopathic. There has been much debate as to the distinction between these descriptors or descriptions. Sociopathy is chiefly characterized as something severely wrong with one's conscience. Psychopathy is characterized as a complete lack of conscience regarding others. Some professionals describe people with this constellation of symptoms as stone cold. For the rights of others, complications of this disorder include imprisonment, drug abuse, and alcoholism. People with this illness may seem charming, but they are likely to be irritable and aggressive as well as irresponsible. They may have numerous somatic complaints and perhaps attempt suicide. Due to their manipulative tendencies, it is difficult to separate what they say about themselves that is true from what is not. Causes: while the exact causes of this disorder are unknown, environmental and genetic factors have been implicated. Genetic factors are suspected since the incidence of antisocial behavior is higher in people with an antisocial biological parent. Environmental factors are believed to contribute to the development of antisocial personality disorder, since a person whose role model had antisocial tendencies is more likely to develop the disorder. About 3% of men and about 1% of women have antisocial personality disorder, with much higher percentages among the prison population. Treatments: antisocial personality disorder is one of the most difficult personality disorders to treat. Individuals rarely seek treatment on their own and may only initiate therapy when mandated by a court. There is no known effective treatment for this disorder. That's sad. Dependent personality disorder symptoms. Dependent personality disorder is characterized by a long-standing need for the person to be taken care of and a fear of being abandoned or separated from important individuals in his or her life. This leads the person to engage in dependent and submissive behaviors that are designed to elicit caregiving behaviors in others. The dependent behavior may be seen as being clingy or clinging on to others, because the person fears they can't live their lives without the help of others. Individuals with dependent personality disorder are often characterized by pessimism and self-doubt, tend to belittle their abilities and assets, and may constantly refer to themselves as stupid. They take criticism and disapproval as proof of their worthlessness and lose faith in themselves. They may seek overprotection and dominance from others. Occupational functioning may be impaired if independent initiative is required. They may avoid positions of responsibility and become anxious when faced with decisions. Social relations tend to be limited to those few people on whom the individual is dependent. chronic physical illness or separation anxiety disorder in childhood or adolescence may predispose an individual to the development of dependent personality disorder. A personality disorder is an enduring pattern of inner experience and behavior that deviates from the norm of the individual's culture. The pattern is seen in two or more of the following areas: cognition, affect, interpersonal functioning, or impulse control. The enduring pattern is inflexible and pervasive across a broad range of personal and social situations. It typically leads to significant distress or impairment in social, work, or other areas of functioning. The pattern is stable and of long duration, and its onset can be tracked back to early adulthood or adolescence. Symptoms of dependent personality disorder is characterized by a pervasive fear that leads to clinging behavior and usually manifests itself by early adulthood. It includes a majority of the following symptoms: has difficulty making everyday decisions without an excessive amount of advice and reassurance from others, needs others to assume responsibility for most major areas of his or her life, has difficulty expressing disagreement with others because of fear of loss of support or approval, has difficulty initiating projects or doing things on his or her own because of a lack of self-confidence in judgment or abilities rather than a lack of motivation or energy, goes to excessive lengths to obtain nutrients and support from others, to the point of volunteering to do things that are unpleasant, feels uncomfortable or helpless when alone because of exaggerated fears of being unable to care for himself or herself, urgently seeks another relationship as a source of care and support when a close relationship ends, is unrealistically preoccupied with fears of being left to take care of himself or herself. Because personality disorders describe long-standing and enduring patterns of behavior, they are most often diagnosed in adulthood. It is uncommon for them to be diagnosed in childhood or adolescence because the child or teen is under constant development, personality changes, and maturation. However, it is diagnosed in a child or teen. The features must have been present for at least 1 year. Dependent personality disorder is diagnosed in between 0.5 and 0.6% of the general population. Like most personality disorders, dependent personality disorder typically will decrease in intensity with age, with many people experiencing few of the most extreme symptoms by the time they are in their 40s or 50s. Causes of dependent personality disorder. Researchers today don't know what causes dependent personality disorder. There are many theories, however, about the possible causes of dependent personality disorder. Most professionals subscribe to a biopsychosocial model of causation. That is, the causes are likely due to biological and genetic factors, social factors such as how a person interacts in their early development with their family and friends and other children, and psychological factors, the individual's personality and temperament shaped by their environment and learned coping skills to deal with stress. This suggests that no single factor is responsible. Rather, it is the complex and likely intertwined nature of all three factors that are important. If a person has this personality disorder, research suggests that there is a slightly increased risk for this disorder to be passed down to their children. Mental retardation. Mental retardation, also known as MR, is a condition diagnosed before age 18, usually in infancy or prior to birth, that includes below average general intellectual function and a lack of the skills necessary for daily living. When onset occurs at age 18 or after, it is called dementia, which can coexist with an MR diagnosis. Intelligence level, as determined by individual standard assessment, is below 70. and the ability to adapt to the demands of normal life is impaired. This is important because it distinguishes a diagnosis of MR from individuals with low IQ scores who are able to adapt to the demands of everyday life. Education, job training, support from family, and individual characteristics such as motivation and personality can all contribute to the ability of individuals with MR to adapt. Other behavioral traits associated with MR, but not being criteria for an MR diagnosis, include aggression, dependency, impulsivity, passivity, self-injury, stubbornness, low self-esteem, and low frustration tolerance. Some may also exhibit mood disorders such as psychotic disorders and attention difficulties, though others are pleasant, otherwise healthy individuals. Sometimes physical traits like shortness in stature, malformation, or facial elements can set individuals with MR apart, while others may have a normal appearance. Mental retardation affects about 1% to 3% of the population. And the symptoms are failure to meet intellectual developmental markers, persistence of infantile behavior, lack of curiosity, decreased learning ability, inability to meet educational demands of school. Deviations in normal adaptive behaviors depend on the severity of the condition. Mild retardation may be associated with a lack of curiosity and quiet behavior. Severe mental retardation is associated with infantile behavior throughout life. The causes of mental retardation are numerous, but a specific reason for mental retardation is determined in only 25% of cases. Failure to adapt normally and grow intellectually may become apparent early in life or, in the case of mild retardation, may not become recognizable until school age or later. An assessment of age-appropriate adaptive behaviors can be made by the use of developmental screening tests. The failure to achieve developmental milestones is suggestive of mental retardation. A family may suspect mental retardation if motor skills, language skills, and self-help skills do not seem to be developing in a child or are developing far more slowly than among the child's peers. The degree of impairment from mental retardation ranges wildly from profound impairment to mild or borderline retardation. Less emphasis is now placed on degree of retardation and more on the amount of intervention and care required for daily life. Causes of mental retardation can be roughly broken down into several categories. Unexplained, that's the largest category. Trauma, prenatal and postnatal, such as oxygen deprivation before, during, or after birth. Infection, genital and postnatal. Chromosomal abnormalities, genetic abnormalities, and inherited metabolic disorders. And just the metabolic disorders. Toxins such as lead or mercury poisoning. Nutritional deficits such as severe malnutrition and environment. Now we are on to Axis 3, and that includes general medical conditions. Listed here are general medical physical concerns that may have a bearing on understanding the patient's mental disorder or in the management of the patient's mental disorder. Axis 4 is psychosocial and environmental. It can be problems related to social environment, occupational problems, educational problems, housing problems, economic problems, problems with access to healthcare services, legal or criminal problems, and problems with a primary support group. Axis 5, the global assessment of functioning, and oftentimes they'll just say GAF or GAF or any combination of the three. This is a number from 1 to 100 that reflects the caregiver's judgment of the overt level of functioning. 100 means no symptoms. 90, minimal symptoms, good functioning. 80, transient symptoms that are expected reactions to psychosocial stressors. 70, mild symptoms or some difficulty in social, occupational, or school functioning. 60, moderate symptoms or moderate difficulty in social, occupational, or school functioning. 50 is serious symptoms or any serious impairment in social, occupational, or school functioning. 40, some impairment in reality testing or communication or major impairment in several areas such as work or school, family relations, judgment, thinking, or mood. 30, behavior is considerably influenced by delusions or hallucinations or serious impairment in communication or judgment or inability to function in almost all areas. 20, some danger of hurting self or others or occasionally fails to maintain minimal personal hygiene or gross impairment in communication. 10, persistent danger of severely hurting self or others or persistent inability to maintain minimal personal hygiene or serious suicidal act with clear expectation of death. I'm going to show you a sample report with Axis diagnosis. So usually psychiatry report will start out with a presenting complaint. Okay, in this case it was a patient reported history of difficulty or of difficult childhood and depression, and then they'll have history of present illness. So they'll go on and talk about, you know, what's presently going on with the patient. And, you know, that can go on for quite a while, as you can see, because they cover everything. You know, if they're into marijuana, drugs, getting into any kind of trouble whatsoever. And then they have a heading, a family history, because that's important, because as we spoke about before, mental illness, you know, to know whether it's a family thing or, you know, or if it's just that person or, you know, what have you. And then, of course, they'll talk about, go in depth about the mental status examination. It's like a physical exam, except for this is all geared to mental status of the person. So, you know, their mood, their speech, and affect and all that. And diagnosis. Now, this is where your access, this is how it ends the report, the diagnosis. And usually, too, you always spell it with diagnosis, S-I-S, even though it looks like there's a whole bunch, but typically we spell it with S-I-S because it's only one axis. You know what I mean? Like axis 1 and axis 2 and then axis 3. So they're considered like single axes of their own. So anyway, just S-I-S. So axis 1, you know, that's when they list whatever, like in this case, post-traumatic stress disorder, alcohol dependence, history of polysubstance abuse. Axis 2, patient has antisocial personality disorder, borderline personality disorder. Axis 3, migraine, headaches, gastroesophageal reflux disease. So axis 3 is usually, you know, other problems the patient's having, other diagnoses and stuff. Axis 4 all deals with legal or social problems. Axis 5, that's your global assessment of functioning. And this patient is functioning between 70 and 75 at the time of this assessment. Now let's test what you have learned. In each of the following scenarios, decide which of the 5 axis diagnosis categories it would belong. A 6-year-old male recently diagnosed with a general developmental disorder. So which axis would that fall under? Give everybody a minute. Think about it. That would be Access 1. So whoever said or thought Access 1, you're correct. Let's see, what's the next one? Okay, a female patient who recently lost her job and is struggling to pay bills. So which access do you think that would fall under? A female patient who recently lost her job and is struggling to pay bills. Access 4. So whoever said Access 4 is correct. A patient who believes he is being spied on by the FBI. Which access do you think that would fall under? Let's see. Access 2. Remember, that's one that lists all the different types of disorders that a person could have or diagnosed with. Okay, a patient who suffers from depression and also has glaucoma. Which access? Well, let's see. Access 3. So whoever said Access 3, you're correct. So that concludes the webinar for today. I hope that it was informative for all you people, and thank you for coming. And I'm sure I will talk to you again and be doing another webinar again in the near future. So I hope everybody has a great rest of the day, and bye for now.